Welcome to the Heart of Healthcare podcast. Hello, listeners, and welcome back to the show. Today, I'm speaking with Prashant Samant, the co-founder and CEO of Akido Labs. Prashant, welcome to the show.
Thanks for having me, Halle. Great to be here.
So your company runs a full stack AI-enabled medical network of 96 clinics that currently supports 500,000 patients. I want to talk about the AI-enabled part. What are you doing unique here?
So there's two parts of it. One is that we build our own technology from the ground up. And two is that we're not selling AI into someone else's workflow. We operate the care delivery system ourselves. That means we design the visit, the staffing model, the follow-up process around AI from the ground up. Most healthcare AI makes existing systems a bit more efficient, and we're using AI to expand care capacity itself.
So what is Scope AI? If you could just walk us through how it actually works in a patient visit.
Sure. So Scope AI is a suite of neural networks that's trained on a massive amount of proprietary data, as well as a reinforcement learning system that we've built in-house that uses our electronic health record and takes information from visits that happen that are quantified, qualified, and fed back into the system. You can think about it as a training environment where we've created one of the world's largest medical textbooks, as well as one of the world's largest multi-specialty residency programs to be able to train a specific medical intelligence. So Scope AI is a medical intelligence that spans 26 different specialties and performs at an attending level of investigation and diagnosis in those specialty areas.
So how does it actually work? Like walk us through what that experience is like in a patient encounter.
So in a scope enabled visit, a medical assistant or a care manager or CHW is with the patient, and scope helps drive the intake, the clinical investigation in real time. It guides the conversation, identifies follow-up question, pulls together the relevant history, generates the documentation, proposed assessment, and plan. Then a provider or physician reviews, edits if necessary, and approves.
Okay.
It's the full cycle.
Yeah. And you guys have your own EHR, or are
We
you
have our own
using
EHR.
something else? You have
Our own
so
EHR.
all of this is trained, like everything is trained on the data that you guys have collected over with your 500,000 patients over the years.
No, before, even more than that. So for the first 5 years of the company's history, like our thesis when we built the organization was that we're going to need a massive amount of organized clinical information. And as you're well aware, in 2010, 2011, that didn't really exist. Still
No.
doesn't really exist. So we spent the first 5 years of the company's history integrating data across a wide variety of systems, healthcare systems, social service systems, and then stitching that together into creating this collection of over 10 million clinical case studies
What?
that are longitudinal.
Wait. You need to pause for a second. You just like said, "Hey, can I have your data? Or can I buy this data?" Like,
So we started the University of Southern California Digital Health Lab. Cerner was just implemented at Keck. And it was a really exciting moment because all of a sudden we had data that was going to be available in theoretically a better way to be able to build models. And from students to professors, we could create technology. We quickly found out that that isn't enough data and it's not organized properly enough. And we also need to enrich that information with social context. And the more you can do that, the better tools you can build that are predicting worsening health and social conditions, as well as being able to automate the care. So those, the kind of the core asset that you need there is a huge amount of data.
Yeah.
And so when we spun this company out of the USCT Health Lab, our North Star was how do we create a really valuable synthetic but organized clinical data asset? And we started working with healthcare organizations around the country for a wide variety of initiatives, from disease management for the CDC to homelessness services coordination for the city of Santa Monica to vaccination coordination for the state of Delaware. And that required integrating a wide variety of different data sources that we fused together. And then we created a representative data population with that, inspired by that real collection of information.
So you were doing research and got access to it. It was essentially part of other projects and work, but it has then gone on to be the input for Scope AI,
Well, that it became a training environment for
training
Scope AI.
environment.
So
Yeah, for Scope AI.
we created a synthetic data system off of
Which means what?
the,
What does that mean?
which means it's fully anonymized. It's representative information, but it's not real patient information, right? So it's like you're creating a virtual, it's like you're making a textbook out of a bunch of clinical case studies. So
Okay.
it's not Halle Techo's information that I'm training off of,
Yeah.
but I'm
Okay.
using like a large amount of data to create a representative enough population that looks and feels and smells like humans on Earth, right?
Yeah.
With enough
And how did you know you
diversity.
could trust it? How did you know that because it's synthetic? How did you
So
know that? Like, yeah.
that's where we can do a huge amount of back testing with these live implementations of data coordination and integration that we were doing in the field. So that was a critical part of the process, right?
Yeah.
It's you're integrating data, deploying a solution to help a program like, care coordination for people experiencing
Yeah.
homelessness in Santa Monica work. And then you're also creating a synthetic data population. And then you can basically test the efficacy of like, is this representative enough? Right.
Yeah.
And you need a lot of scale for this. You can't just do it with
Yeah.
like a small subset. So we have, to my knowledge, the largest collection of longitudinal clinical case studies that are enriched with social context that are representative of how human beings operate at about 10
Wow.
million. And so that's what I would call, like, in this
Yeah.
analogy, like the medical textbook part of it.
Yeah.
And then the residency program is our online training system, which is the REHR that our doctors use, our providers use, that sees real patients. And
Yeah.
so as we bubble up an algorithmic recommendation, whether it's working in the moment or whether it's working in the background, a physician's interaction with that, whether it's accurate, inaccurate, feeds back into our system, right?
Yeah.
Kind of like how a resident shadows an attending and the attending asks them a question and they say, nope, you're wrong. They have to learn. That's their feedback system, right?
Yeah.
But unlike, our scope is trained to be an omni specialist, right? So you're getting that feedback from all of the doctors, all of
Yeah.
the providers across our system. And that's fed into one brain as opposed to multiple different brains, which is how it happens in a residency program.
Yeah.
So that
And
is
you
the
don't,
technological
yeah.
history.
And you guys have a huge dev team, but you have no intentions of selling the software to other providers. The
Um,
software is for you guys to be the best at what you do.
is our current approach in bringing this to the world. I mean, I think that there is, like, in healthcare, one, workflow is the product ultimately. Software is enabler, workflow is the product. So we feel
Mhm.
pretty strongly about that. I think that whether we provide the software, take Scope AI as a technology, softwareify and deploy it, would we see the same impact that we're getting from being able to re-engineer the workflow around this technology? I don't think so in the short run. So I just think that purely from a social
Yeah.
mission standpoint, I don't know if it's the best way to get this into the world and actually see substantive
Yeah.
effect. So I think that's mostly where it comes from, where it's like, again, leading innovation at an academic medical center, which we have done. I've seen how challenging it is to really drive transformation with new software
Mm.
adoption. So it feels like we can achieve our mission better, faster, and more comprehensively,
Being
and
full
with the
stack.
right, yeah, also with like the right kind of moral guardrails, like we want to focus on difficult populations. That's
Yeah.
where we need to make the stuff work first. And
Yeah.
I don't know if we sold the software, if it would find its way into that same sort of use case area.
You've tested out a lot of things, but just in terms of all of the other work that you've done to make your providers at the 96 clinics better prepared and work faster, like what have you tried that has worked? And then is there anything that you tested out within your clinics that did not work?
Constantly, constantly. In healthcare, if you're actually deploying technology in the real world, a lot of learning comes from what doesn't work the first time. One of the biggest lessons is that technical capability and operational adoption are fundamentally different problems. Sometimes the model is ready before the workflow is. So we have to iterate in a live care setting and keep tightening the connection between the technology and the real world care model. I think that that living laboratory reality is what allows us to build technology more rapidly because it's technology that's actually going to work and drive impact.
Yeah. How does your care team though respond to that? Like you try something, maybe they start working on it, 6 months, they get used to it, and then you're like, actually, this isn't working. We're going to move on to something else. Like, how do they respond to that given, traditionally clinicians resist trying new things?
That's a really good question. Well, I would, a little biased here, but I think that we have the best care team in the world. And
So
so I
you
think
hire
just
you hire
pure,
for this. You hire for
I,
folks
th-
that'll yeah.
I think that I think that you have to approach it in a way that is solving their problems, whether it is problems that are associated with being overextended, challenges they may be having with a particular kind of visit scenario. So you have to take a really human-centered design approach here, and I think that's been an
Mhm.
integral part of the company's history. We're over 1,300 people, and half the organization looks and smells and feels like a big data foundation tech organization. Half the company looks and smells and feels like a
Yeah.
multi-specialty healthcare system. And so, in that marriage, you have a lot of human-centered design that goes into making that technology adoptable. So it starts with problems that our care teams face. And if you're solving problems that the care teams face practically, then it's not just, hey, let me force feed you this technology and now you have to use it, but it's something
Yeah.
that is absorbed because it's actually solving their problem in real time.
Yeah.
Like a very
Okay.
simple example of that that's
Yeah,
obviously
yeah.
worked is scribes, right? Like scribing technology revolution that's happened is solving a real problem.
Yeah, and you chose not to buy one of the many vendors that offer that out of the box.
Correct. We feel like capturing the conversation and the dialogue and how that conversation develops and flows between a care team and a patient is an important part of is an important part of our data asset. So we can understand how to better train models that are going to investigate more thoroughly, more completely. So it was really important for us to be able to build that in-house and have that in-house.
Interesting. So it's a strategy decision versus like a financial. Like it's not that it's cheaper to build it on your own, but like it goes towards your strategy of owning end to end the data piece.
I think it's a bit of both. I mean, I think that, healthcare is one of those spaces where if you are able to create an environment that is operating at scale from a health system point of view, and you're, again, really able to adopt a human-centered design approach in improving that environment and then build a technology organization, engineering, product management that is truly
Yeah.
in service of that. It's pretty amazing how much you can build more cost effectively and more optimized for your particular care environment. I think that for a lot of vendors in healthcare, you're selling into a alien care environment. And I think that's what makes it much more
Yeah.
challenging. But once you're on the
Okay.
inside of it,
Yeah.
yeah, you can build a lot more efficiently too.
Yeah. Let's talk about the street medicine work that you are doing. You just published a study about this work. You wrote a paper. We're going to share it in the show notes. In it, you argue that if AI powered care can work on the streets of LA, it can work anywhere. Tell us about this project because this is not your initial target population. This is something that you guys have been doing more recently. Why start with the unhoused population? I imagine they have very deep-seated mistrust. I imagine they're very hard to follow up with, might not have phones or email. I mean, you could have picked literally any other easier demographic. Like, tell us how this project came to be, and then we can get into some of your findings.
Yeah, I think part of it, at a high level connects to the mission of the organization. We're a social enterprise. Been that way since we've founded the organization. And so it's being not just able to not just bring technology to the folks that have service right now, but to be able to democratize the benefit of technological improvements to equalize care. And as you mentioned, yeah, the people experiencing homelessness population is a very, very challenged population for all the
Yeah.
reasons you mentioned, not to mention the fact that they have a lot of comorbidities as well. And so if our model only works on easy patients, quote unquote, it's not a healthcare breakthrough. It's a convenience product.
Yeah.
And we started, we wanted to make sure that as we designed the workflow around this technology, wanted to focus on populations that the system fails most visibly. And if you can
Yeah.
build a model that works here, you're solving a real access problem in American healthcare. And philosophically, again, these populations are often the latent beneficiaries of this kind of technology, and so starting there not only is aligned with the mission, but it's ensuring that we're building technology in a way and designing technology in a way that is truly going to be inclusive. If you're using design principles that only benefit, again, the people that may be able to spend additional dollars on being able to
Hmm.
get access to more care, then you're going to be tilting design in that direction versus solving the challenges around how do we build better trust? How do we build more comfort? How do we solve problems like being able to record in the field? Like these are challenges
Yeah.
that exist because this population is very unique.
Yeah. And your foundational unit for this is this pod with one provider, 8 community health workers for every 350 patients. Just doing the math in my head, my primary care physician has a patient panel of over 2,000 patients. How do you make that math work? Because that's actually not as efficient as like a traditional primary care model.
That's right. I mean, it works because it's designed for a very different job. A traditional PCP panel may look large on paper, but a lot of those patients don't get the intensity of engagement they actually need, especially in a high complexity population. Our pod is built for trust, for follow-up, for coordination, and the community health workers who are not extra overhead, they're part of how care model actually works. So
Hmm.
it's creating a pod structure and specialized labor that's solving the unique needs of this particular population.
Yeah. And what are the community health workers? What are their backgrounds? Where are you finding them?
I mean, a lot of our focus is on lived experience and some level of exposure to this population, some level of exposure to vulnerable communities in general. One, it helps build a tremendous amount of trust and
Yeah.
empathy with the individuals we're trying to serve. And two, we want to be able to provide, a system for being able to help the population we're trying to serve not just get better from a health and well-being standpoint, but from a financial standpoint as well.
So tell me what the community health worker does on a day-to-day basis. What does their job look like?
So field medicine is inherent to our street medicine program. And you have people, community health workers, as well as practitioners that are in the field going from tent community to tent community, shelter to where our patients are. And in that setting, they're engaging with them, building trust, building rapport, checking in on them both personally as well as medically as well as socially. So not just ensuring that they're getting the medical treatment they need, but also being connected to various that are a part of
Mhm.
improving the well-being of this population.
Yep. And do they have like they're going into, let's say, a street with like a number of folks who are living there. Do they have like, these are my patients, I need to go find these specific people? Or is it more like, I'm gonna sign you up and now you're part of our community?
It's a combination of both. It's a combination
Okay.
of both. I mean, we're in being able to increase the capacity of this program. The goal is to work with our partners. It could be, for instance, Hopix in the LA area, which is a social services infrastructure that provides housing, for instance, to show up there, make sure that their beneficiaries are able to access this program. So that might mean a combination of enrolling new patients into this program and starting them on this process, as well as doing follow-ups on existing patients. And I think the benefit of technology like Scope AI and how that transforms the nature of this care model is that we can better optimize the time of not just the physicians, but also optimize the time of our caseworkers, so that they're doing follow-ups for the for the right population, for the
Yeah.
right segment of patients. They're able to optimize their time enrolling new patients, and it just makes the entire system work better.
Yeah. I mean, they're bringing what would otherwise be a doctor's office to the street and serving people where they are. But as
Yeah.
you've said, like this is a mobile population. These are folks who might, just like pick up and start walking and go somewhere else. How do you keep geographic ties to these folks? And then how many kind of just like drop off and disappear versus how many are you able to maintain contact with?
Gosh, we have an incredibly high level of enrollment. I think that the over 80% of our patients are retained, and that's largely because
Wow.
of the increased level of touch points that we can provide through a AI native care model. I think there's a couple
Yeah.
things you touched on there, and I think what our street medicine team does with this technology is it's like bringing the best of what science fiction allows for, as well as the best of community organizing. And so when you're
Mm,
going out into the field, these people that we're able to work with are motivated to be able to engage the community in an earnest, honest, direct way.
yeah.
And the reach that we can allow them to leverage now changes quite significantly. So if you have to travel, let's say 2 hours into a rural part of a region that we're providing care to, you have like 20 minutes to both build rapport with that individual, with that patient, get the medical investigation done that you have to, and then
Yeah.
also figure out what social service follow-ups are necessary, right? And our team is willing to do that right now, and that's just the nature of these people that we're blessed to work with. But
Yeah.
by being able to have technology like Scope AI that allows a caseworker to be in that field and, like you said, bring a medical office to that destination means that our physicians can oversee a much wider territory because they aren't having to necessarily go out and do that 2 hour
Yeah.
drive there and back. Also, it's not just one kind of care we're able to bring to that situation. It's a multi-specialty care because Scope is trained across 26 different specialties. And so you're not just bringing, cardiology care or endocrinology care or general PCP oversight, but you're able to do a full medical visit across a multiple range of issue areas which these patients are going to be dealing with, all within that 20-minute time horizon. And once we're past that window, that
Yeah.
person's gone. They probably moved on to a different area. So
Yeah.
those moments and touch points are really important to maximize.
What's in front of the provider? Is it a cell phone, an iPad? Like, what is it that they're using to engage with Scope AI?
Generally, it can operate on an iPad, on a phone,
Okay.
also through a pure audio system, as often as the circumstance allows for. Have an iPad that has, like a full ongoing list of next best questions to ask that are navigated
Ah,
by scope.
yeah.
And so you can think about it like an intelligent teleprompter that's listening to the conversation, that's updating the next best question, similar to how you might imagine a physician's office visit being, right?
Yeah.
Where you show up with a chief complaint, maybe a couple of what they would call a chief complaint, and a couple of symptoms, and then it's on the onus of the physician to ask you the next best question to go to kind of tease out what that full case study is of what's happening to you, right? Scope is doing that, and it's navigating the care manager, the caseworker, to ask that next best question and collect that answer, so we get
Yeah.
a full differential done.
I truly need that for this podcast too. So when you guys are done tackling healthcare, that would be so helpful to have like, here's the next question you should ask. So speaking of the next question I should ask, so the data that you guys published shows a 31% reduction in emergency department visits amongst these patients. Are Medicaid managed care plans actually paying you for these savings? Do you have some sort of value-based contract in place? Or are you still fighting the like structural deficit of traditional reimbursement?
Yeah. Well, healthcare reimbursement often lags behind care innovation. So the answer is in some
Yes.
places, yes.
Okay.
And in some places, the system still hasn't caught up. But
Yep.
the direction is very clear. Plans are under enormous pressure to improve outcomes and lower costs for high needs populations. And
Yep.
models like this can do both, that can do both, excuse me, will become increasingly important.
Yeah. So are you working with Medi-Cal?
We are working with Medicaid. Medicaid is a big,
Yeah.
big partner of ours. To well, one of the principles in designing this technology and designing scope and scope orchestrated workflow, and the care models that are possible because of scope orchestrated workflow. One of
Yeah.
our design principles is we wanted to make sure that everything can operate in today's payment rails. So not
Okay.
having a an out of pocket requirement that is abnormal to a patient, not requiring some magic new way of getting paid for, but
Yeah.
work
I mean,
within the existing reimbursement regime on
yeah.
both the Medicaid side, on the commercial side, on the Medicare side, the value based care side, the fee for service side. So you can think about it as like we are just a health system. We have a lot of patients across all different
Yep.
kinds of reimbursement regimes.
Yeah. I mean, but Medicaid is probably the most notoriously difficult to make work financially, not to mention all of the recent cuts. But you're running towards that, whereas others would look at this time in Medicaid and say, and people literally are pulling back and saying, I can't serve this population anymore. And you're doing the opposite. You're running towards it.
The traditional way to respond to Medicaid is to cut capacity. And yeah, we think that's exactly backwards. In our opinion, the
Sorry,
only
what do you mean by
durable,
that? What do you mean by that? It's for a provider to cut capacity?
yeah, you generally have to find some ways to reduce services, reduce staff,
Okay.
and,
Like bare
you know,
bones care.
that has historically been the response to increasing Medicaid pressure because of just, one, the existing reimbursement construct to it, and also
Yeah.
the challenge of the patient population oftentimes. And so we live in a world of healthcare scarcity. That's just the underpinning here. That's what the fundamental issue is here. And so when your most challenging revenue environment has increasing pressure, like the only option you generally have historically is to find ways to cut that capacity or to cut the cost structure associated with servicing that needs area. And yes, we think that is exactly backwards. Think the only
Mm,
durable answer is to lower the cost of delivering high quality care while increasing access. And if you can redesign workflows so that a provider can care for more patients effectively and reduce avoidable downstream utilization, the economics start to work much, much better. And there are both value-based care programs that start to make sense financially. There are incentive programs like ECM
yeah.
here in California that are really powerful, but I think there is a world we can imagine that is both sustainable and high impact, but it does require increasing the capacity and the capability of our providers.
Yeah. I mean, the irony of it, as we talk about all the time in healthcare, is that like we're paying for it one way or the other, right? So if someone ends up in the emergency department, we're paying for that. If someone is out of work because not because they can't work, but because they're sick, we're paying for that. It's an economic problem for us, yet very few programs are willing to invest what they need to actually keep people healthy.
I
Um,
think I think you're absolutely right about it. I mean, I think that's something that I think sometimes people think that, oh, if we make it less, let's say we're saying, we want to cut costs in Medicare as a society or in Medicaid as a society, and that's going to be better for our taxpayers.
yeah.
The practical truth is that these are all interconnected systems. So it
Yep.
sounds simple on paper, but the reality of what you're doing is you are resulting in increased ED utilization and
Yep.
a lot of other social services that aren't even connected to
Lower
healthcare. You know what I mean?
productivity, like, it's bad for our economy.
It's bad for our economy.
Sick people are expensive and they're not productive, so it's yeah.
And here's the thing, right? If you're a specialty care provider within a geography and you're, an organization that employs those specialty care providers, say cardiologists, endocrinologists,
Yeah.
if all of a sudden a third of your patient base, since it's going to be Medicare, Medicaid, and commercial, but,
Yeah.
a third of that stack is going to be less revenue per patient, it doesn't just it messes up your entire business model.
Yeah.
Your practice may not be able to survive because you have to see the
Yeah.
patients, right?
Yeah.
Like there isn't somebody
Yeah.
else. There isn't a magic place they can go to. So I think that
Yeah.
it's pretty short-sighted thinking, and creates a huge amount of strain on our safety net, which includes the entirety of the healthcare spend as well as other social infrastructure.
Yeah. Absolutely. So you talked about provider shortage, and we have these enormous constraints. There's a projected deficit of 86,000 doctors by 2036, and you have said that we can't just train our way out of the crisis. So, do you think that AI is the only way to prevent just a total collapse of our safety net?
Yeah, I think it is. I think that I don't, I think I can be pretty binary here. Yeah, I think it is. I think that the problem is that there is a reality of intelligence and capacity required to provide care services. Like
Yeah.
that's just necessary. Like we have to be able to, and even the the most um, like hardworking, overextended physicians, like right now, oftentimes, they're just not going to be able to provide the full scale of medical knowledge that a patient needs to be able to, to determine what the next best well-being step is holistically. Partially because we also
Yeah.
have siloing medicine, so it's not just it's an undercapacity issue; it's also a siloing issue.
Yeah.
My parents are my mom's a gynecologist. My dad's an ER doctor. They have two different fields of knowledge. My dad will be like, I do not know exactly what to do with all the patients that your mom deals with. And so,
Yeah.
I think that what AI allows for is to be able to, um, you know, disconnect medical intelligence availability's reliance on an individual human.
Yeah.
Um, Not the responsibility side, not the oversight side, but just the availability of being able to bring that medical knowledge into a situation. When you're able to do that, you can imagine a far greater level of applicability of that knowledge than is possible, even if we had 10x the amount of humans. Right, a lot more
Hmm.
availability than 10x the amount of humans. You make things like continuous monitoring more possible, like whole person care possible for everybody, as opposed to
Yeah.
people that are just ultra wealthy that can afford to have a personal chief medical officer and then 10 different specialists that they're paying for on an ongoing basis. Like
Yeah.
that reality of being wrapped in medical knowledge as a human, as an individual patient is now possible for everybody. So I think
Yeah.
that it is the best answer that we have to being able to cloak every individual person in continuous medical monitoring.
Yeah. Yeah, humans are expensive inherently. Some people worry though that we're going to create this healthcare system where those who can afford it will see humans and the rest of us will see AI. And probably folks like you and me will be like, great, like I love an AI doctor that's around the clock. But I think that there's a lot of fear around creating this two-tiered system. How would you respond to someone who has that concern?
Well, for starters, right now we have a two-tiered system that exists where
We sure do.
somebody gets care and someone doesn't get care. So let's start with
Hmm.
that. Like for me, the most important thing to solve there is how do we get care at a base level for everybody, period, full stop,
Yeah.
and bridge those issues between kind of not just lifespan of the people who have and the lifespan of the people who have not, but the health span, like the quality of life they have over a period of time.
Yeah.
I think that increasing the availability of care, period, will be the most impactful thing in reducing that gap that we've ever seen in human history, period, full stop. Number two is that I think that once you're able to increase the amount of available medical intelligence that's standardized, science based, unilaterally applicable, I think the nature of the healthcare system is going to shift. And I think we've seen this in other disciplines as well. In the future, the nature of what a knowledge worker in healthcare is going to be doing and what a physician is going to be doing is just going to be very, very different. So I don't think it's going to be like, I don't think it's going to be a world where I have my personalized technician and then everybody else gets an AI robot that they have to chat with. I think it's going to be that we're all going to be using some level of interface with technology, and that physicians are going to be being kind of, how we think about engineers now. They're going to be doing technical work as well, but they're also going to be doing kind of broad-based field general work
Yeah.
for everybody. That's my take.
Yeah. So how do your parents feel about you not becoming a doctor?
Well, very disappointed for a very long time, but I think what I'm really excited about. So my mom was a physician in Alameda County Medical Center most of her career, which is, I don't know
Wow.
if you're familiar with that health system, but in the 90s it was a tough place to work. And she's really, she pushed me to. I had to volunteer at the AIDS clinic there pretty much every summer, and just saw her work
Amazing. Yeah.
insane hours. Um,
Mhm.
and because it's important to her. Like, she's one of those people that's like born to be a medicine, like born to be a doctor.
Yeah.
And what I'm really excited about is that as we launch our Bay Area program, she's going to be part of that whole person care team that's going to be treating a patient population she really cares about, recently incarcerated and vulnerable women as part of the Aikido care system. So I think her last job in medicine
Amazing.
is going to be working for
Oh, I love that.
her
Yeah, are you gonna
son's.
be a tough boss for her, or are you gonna go easy on her?
I think she's still my boss no matter what
Yeah,
I do.
yeah,
So, so yeah,
I
I
love
think
that.
that they're
Yeah,
you know
and
they're
your
excited to be able
dad,
to do
you
that.
said emergency room doctor.
Emergency room doctor, yeah,
Yeah,
yeah. So, um, yeah. So I think that they acknowledge that the you know I think that they acknowledge that if we really want to systemically address the inequities in healthcare access and quality, that it isn't just a problem that we can solve with more bodies. It's a problem. It's a problem
yeah,
we have
we
to
need to do the
re-engineer the
opposite.
system.
Yeah, we need the
Yeah.
opposite. We figure out how to have fewer bodies. So Prashant, one last question that I like to ask all of my guests: if you could wave a magic wand and change one thing about how the U.S. healthcare system works, what would it be?
I I would change the system so that it could adopt better care models as fast as technology makes it possible. I think the limiting factor isn't whether or not we can build better tools, it's whether the healthcare system can absorb them and operationalize them
Mm,
at speed. And I think that when that infrastructure lags, the people who suffer the most are the people who have the least amount of access. It's that simple. If you
yeah,
have means, you can circumvent the lagging system and get your hands on the best technology, whether that's, pay out of pocket, whether that is travel internationally, whether that is buy the next coolest wearable, whatever means solves that. And so I think that, there's no secret that there's technology that we've experienced in our personal lives that we still don't experience in the healthcare system. I think that the
yeah,
average consumer web app is better than like the most expensively built patient portal, right? And so
yeah,
I think that that would be the major thing that I would address. I think that being able to absorb technology faster.
yeah.
Um,
Awesome. Well, Prashant, thank you so much for your time today.
Thank you for your time. Thank you for having me here.